Chairman to the stage, Professor Abdallah bin Nahi, Professor Amr Abdel Wahab, Professor Munira Al-Arrouj.
Now we'll start our second session. I'm so pleased to put this session with my colleagues and friends from Kuwait, Professor Munira Al-Arrouj, Professor Abdallah bin Nahi. Our first speaker will be Professor Mohammed Hassani. His talk will be on the adding years to life, diabetes treatment beyond glycemic control.
Thank you very much, Dr. Abdel Wahab, and very good friends, Dr. Munira and Dr. Abdallah bin Nahi. It's a great pleasure to see everyone here in the room, and hope you enjoy your stay in Cairo. We're all in Egypt very happy. After 48 hours or so of, I'm from Alexandria, this is a photo of Alexandria, and Alexandria was a city where all of Egypt was happy 2 days ago after Salah scoring 2 goals and getting Egypt into the World Cup. So hopefully you will be as happy as all of us with the conference today. Now, back to the topic of enjoying happy life and diabetes, and adding years to life or preventing loss of years. Because we know in type 2 diabetes that men and women in the 50s, they can lose roughly about 6 years of their life if they do not tackle the cardiovascular risk factors or many of the other risk factors as well. So it's really quite important to think of how can we prevent this beyond glycemic control. Now, glycemic control itself is important, and really to get to the objective of any treatment, we need to try to achieve the target, optimize the tolerability and adherence of the people with diabetes, and eventually aim for improving survival. And because of this, we get many guidelines. ADA algorithm is the one that many people use, although I'm not really sure that it is the best one. When you think of the algorithm, you will see here 6 choices of different classes of drugs. Which of them would be a drug that can help you to add years to life or to prevent years to life? And this is in a person who does not have cardiovascular disease already. I don't think we have any doubts about microvascular complications. Glycemic improvement can improve microvascular complications, neuropathy, nephropathy, and retinopathy. But when it comes to macrovascular complications, I think there is some evidence, although it's not as strong as the microvascular complications. So this is important to remember. However, if you were to ask yourself which drug which I would use out of this group, Professor Benedetti from Italy is here with us, and this excellent study from Italy just presented 3 weeks ago, the TOSCA trial, was presented at the AASD and was published shortly afterwards in the Lancet. The TOSCA trial simply tried to answer an important question. If we start after metformin is failing, if we start with pioglitazone, is it better than starting sulfonylurea? many people were concerned about sulfonylureas in the past and the preconditioning of the myocardium, and so many of the queries, the hypoglycemia and so forth. And this is an independent study where they have looked into people aged 50 or above, for not well controlled on metformin, well tolerated dose, and was up to 57 months, so nearly 5 years of follow-up. And as you can see here, it's a decent number of patients from each arm, or from each, roughly about 3,000 persons in the study. And the sulfonylurea used is the modern sulfonylurea. Only 2% on glibenclamide, the rest on glybepride or glycoside, so more of the modern sulfonylureas. And the answer is, can you see here? The study was stopped after 5 years. There is no difference between starting pioglitazone or starting sulfonylurea for 5 years from cardiovascular point of view. And this is their this is the conclusion. And they, of course, this is reassuring to us because as they have concluded, these two classes of drugs are very important, they are affordable, and we are talking in Egypt or in Middle East, where in many countries affordability is really quite important. So when affordability is also matched with no harm, then it is quite reassuring. So going back to the same question, what if the person have cardiovascular disease? Now, it's clear that we have plenty of cardiovascular outcome trials. Many of them has already been published. These are the data for the DP4 inhibitors, and it told us no difference between one and the other. They do not cause harm, and equally, they do not add extra benefit for cardiovascular protection. SGLT2 inhibitors is largely a new class of drugs that have been out in the market for a short number of years, and we have the EMPEREG trial and we have the CANVAS trial. Both of them have shown improvement in cardiovascular outcome beyond glycemic control. So the outcome here is not related to improvement in glycemic control, it is more related to the effect of the drug itself. I have no time to go to the ins and outs and the caveats in every study, stroke or amputations or osteoporosis or whatever, but really these are the headlines. Equally, in GLP-1 receptor agonist, there was a number of studies. Excel was also presented a month ago. In AASD, less than a month ago, it was presented, and it's the Bydureon long-acting exenatide for a number of years, looking into cardiovascular outcome, equally showed non-inferiority but no added benefit. Lixexenatide was presented a couple of years ago and showed the same outcome. Liraglutide, on the other hand, have shown benefit. So hence the ADA is one of the guidelines, similar to the Canadian, that have said if your patient is not well controlled with moderately long type 2 diabetes and with cardiovascular disease, then you should consider empagliflozin or liraglutide. Whether it will change in 2018, whether it will add other drugs or not, I'm not really too sure. So the first point is, if there is no cardiovascular disease, any drug is equal. If there is cardiovascular disease, you need to think of which one would be better than the other. Now, beyond glycemic control is really quite important. STELO trial was a remarkable trial because it did what every one of you do in their own clinic. They simply try to address everything. And if you focus on the STELO trial, which of the parameters of the STELO trial were more important? And as you can see here, it's the systolic blood pressure and it's the LDL which really have huge difference. Diastolic blood pressure didn't really make a significant change. So when it comes to hyperlipidemia, there's a big question that we'll face all in our clinics. Which patients should we treat, and why should we treat them, and how should we treat them? Now, I like this algorithm from the ADA because it has answered many of the questions. So if you are treating a young person below the age of 40, and this person has no cardiovascular risk factors at all, then you do not need to start a statin. And that's important if you're treating a young female in the reproductive age. But these are the rarity, because the vast majority of people with type 2 diabetes will have cardiovascular risks. So if they have cardiovascular risks, then you would add a moderate to high intensity statin. If they are below the age of 40 and with an established atherosclerotic cardiovascular disease, then you need to start a high intensity statin. If they're above the age of 40, you will have to give them treatment due to virtue of type 2 diabetes and the fact they're above the age of 40. No one really above the age of 40, according to the guidelines, is exempt from statin therapy unless they have other problems, side effects, or liver problems. What is the strength? The minority will be moderate if they have no cardiovascular risk factors, but if they have cardiovascular risk factors, then it's a high intensity. What do we mean by high and moderate intensity? There is only 2 drugs in the high intensity, rosuvastatin and atorvastatin, and the doses are mentioned here. The others are moderate intensity. So, is there a strong role for fibrates, for combination therapy? Of course, intensification of the lifestyle is the most important step in disease management, in diabetes, in hypertension, and in hyperlipidemia. We don't talk too much about it because it's a given. It's a must for all of our patients. Fibrates management nowadays is not for cardiovascular protection. We rarely have evidence for this. Fibrates management is largely for prevention of secondary pancreatitis. And it's only indicated when the triglycerides level is quite high. If the patient is not tolerating high doses of statin, is there a role for combination with ezetimibe? And we have a study, and what you see here in front of you is a copy and paste from the ADA guidelines. Yes, if your patient is high risk and not achieving the target on a high dose statin, then there is a role for this. There is one important point which I need to mention. Nowadays there is other treatment. It's quite expensive, it's injectable, it's TSK9 inhibitors, and they're available as injection. They're indicated in people where they have been on the highest dose of the statin and they are already with a previous cardiovascular event, but they're not achieving their target and the role. Please don't insist on asking for fasting lipids. There is no need to ask for fasting lipids profile. All the societies have now been saying for a number of years, the level of lipids, fasting or non-fasting, hardly change. And I will show you why. So as you can see here, cholesterol and LDL and HDL do not change very much by the hours of fasting. The only one which changes is triglycerides. So if your patient's non-fasting lipid profile, triglycerides, is very high to the extent that you consider treatment for pancreatitis, because we've already mentioned it doesn't change the cardiovascular outcome very much, then you can ask for fasting lipids profile. Otherwise, your patient is diabetic, they might be on hypoglycemic drugs, they might be on insulin, it's a restriction. They can go to the lab at any time of the day, and this recommendation is from the European Society, from the Heart Society, from a number of societies as well as the ADA. So it's good to add sort of quality of life for our patients. Hypertension is huge. I'm going to touch on it very briefly to say that the data that is coming from WHO about hypertension prevalence, especially in our region where we love our salt food and we also don't have the best of lifestyle, is quite high. The minority of patients, only 18% of patients are treated to the target. What is the latest target? Or the guidelines, obviously, I have been part of these guidelines from UK in the past, and in the past we used to say A or C. A is any of the ACE or angiotensin II antagonists. And then you add C, and then you can possibly add the three together. One new theme in hypertension treatment now. The treatment is dependent on intensity. So if the blood pressure is moderately high, with lifestyle you can start monotherapy. If the blood pressure is over 160 over 100, then combination therapy from the beginning would be advocated. So that's now a change in themes, rather than start with one and then add a second and then a third. If the blood pressure is too high, you might consider adding two together. And the same was in the European organizations, monotherapy, single tablet versus 2 tablets, dependent on the intensity of the blood pressure. Blood pressure treatment in meta-analysis, for the sake of blood pressure, are all equal. They are only different when it comes to end organ disease. So if a person with nephropathy, then, or heart failure, ACE inhibitors or angiotensin II antagonists would be indicated. Shisha and smoking are now everywhere. I'm not standing here to preach, but they become global. And it is never too late to advise your patient to stop smoking. So as you can see from this paper, the risk of the ex-smoker is far much lower than the risk of the current smoker. So even though your patient has been maybe smoking for 20 or 30 years, nevertheless, it's quite important that we focus on the other factors rather than focusing on reducing HbA1c from 8 to 7.5, when that will hardly change years to the person's life in comparison to smoking cessation. So as you can see from this trial published in 1999, cessation can halve the risk during 1 to 13 years of follow-up, which was published in the European Journal of Heart. Lastly, should we give our patient aspirin? All our patients will give them aspirin. Aspirin, we know, is fantastic for secondary prevention. But when it comes to primary prevention, the recommendation says for men or people above the age of 50, but below the age of 50, you need to have other cardiovascular risk factors for end organ disease. At some stage, we were giving aspirin to almost every person at the time of diagnosis with a statin and maybe with an ACE inhibitor. We don't need to do that anymore. Of course, at the end of the day, it's the lifestyle, and don't forget the physical activity and the weight and the inactivity, which is quite prevalent. And I think this is largely related to portion size. It's difficult to say to someone, don't eat, but to control the portion would be a problem. I'm glad you did not see me at breakfast time having 2 pieces of fatir. So that was my sin today, because I don't have this available where I live. So thank you again. I mean, my conclusion is it's important to try to achieve the targets, and when it comes to glycemic control, the choice of treatment would be important only when you have cardiovascular disease. If you don't have cardiovascular disease, all the classes are currently with equal level of evidence. Side effects is important, and tolerability for the patient, as well as, of course, affordability. The lifestyle we should not forget, it's really quite important. Achieving the targets is quite important, and I will throw again the slide again, because it made us all very happy. Thank you very much.
Thank you, Dr. Hassanein, for this presentation. Please join us in the panel, and we'll move on to our second speaker. And it's really my pleasure to introduce my personal friend, Professor Massimo Benedetti from Italy. Professor Massimo Benedetti is a well-known international figure. He has been involved in so many international organizations with so many important posts. You can go through his biography in the booklet. And we have, in fact,